welcome. I'm Heather McLean, and today I'm going to be interviewing two very talented family practice doctors, and they are going to discuss why they are now integrative doctors or more holistic based doctors. And they're going to discuss the current medical model of treatment in the United States and why a certain subset or population of people with chronic disease tend to fall through the cracks in that method of treatment, and how holistic treatment or integrative treatment might differ from that in their approach. We also discuss a lot about nutrition and why nutrition affects your immune system. And when you're fighting chronic disease, you need a good immune system, and so it's a good place to start. I hope you stick around. We're a little chair challenged, so I'm in a very tall chair. That was because of the area we're in, so we made do with what we had, and the content of the interview is excellent, so I hope you stick around and enjoy the footage at the end of the wild and woolly Northern California coast. Thank you. And welcome. Today I'm going to be interviewing, I have Neil Nathan, Dr. Neil Nathan, and he is in Fort Bragg, California, and I also have my husband, Jeff Greenfield, and he's a doctor of osteopathy, and we work out of Manchester. And I would like Neil to kind of introduce himself a little bit and talk about what you do, how you're different than other doctors out there perhaps, and then we'll go to Jeff.
Okay, I'm Neil Nathan. I practice in Fort Bragg and Santa Rosa, California at Gordon Medical Associates. I have been practicing for 42 years. I am board certified in family medicine and in holistic medicine as well. And for many, many years, my practice has been to care for people that conventional medicine doesn't quite know what to do with. And what that would mean would be people who had chronic fatigue, fibromyalgia, Lyme disease, autism, mold toxicity, a wide variety of chronic illnesses that conventional medicine hasn't quite known what category to put them in and quite hasn't known what to do with them. So I slowly went from being a conventional family physician, delivering babies, working in the emergency room, to now I primarily work with what we now call complicated medical problems.
Okay, so the chronic disease
Right.
model. Okay, people who have fallen through the medical cracks, and you've also written a book, and it's now called Healing is Possible?
Right. I wrote, my first book was Hope and Healing for Those Who've Fallen Through the Medical Cracks, and my new book will be released in May, and it's called Healing is Possible for Those with Chronic Fatigue, Fibromyalgia, and Other Chronic Illness.
Okay, and we'll get into some of that. And first, I'm going to talk, next I'm going to talk to my husband and have him introduce himself as well.
I'm Jeff Greenfield, and I practice out of Manchester, New Hampshire, and I have a small office up in Camden, New Hampshire as well. I am board certified family physician and board certified in neuromusculoskeletal medicine, which is a fancy name for osteopathic manipulative treatment. And my practice is a unique practice in that I use my hands all the time, treating people in a certain style of osteopathy, where people actually get benefit from the treatments, but I get a whole lot of information about what's going on in their body. And over time, that's also led me to this whole integrative approach, or what we would call non-conventional approaches to medicine, which actually should be the more conventional approaches to medicine. Because I found that prescribing pills and doing the like didn't really help my patients get well. So I started on a quest to learn more about it, and Dr. Nathan and I met about 30 years ago when I was still a medical student, and pretty much he's helped me and nudged me along in this, and I came out to study with him for a week or so to learn more about what he does out at Gordon. So I guess I would be considered a osteopathic manipulative doctor who does integrative medicine, treating similar people as Dr. Nathan does.
Excellent. So we have two alternative doctors in a sense, but very conventionally trained.
We were going to talk about how is what we do different than conventional medicine. Why do we call it alternative? And I think the answer to that question is in understanding the philosophical underpinning of conventional medicine, which is that conventional medicine is based on what we would call an acute care model. We have an illness, we figure out what that illness is, and we treat that illness. And the key to that is that it is a one-cause process. So examples for that would be if you had a strep infection, we do a culture for strep, we can determine that very quickly, and then we can provide penicillin, and that will cure it. And we're all happy. We can break our arm, we can take an x-ray, we know exactly where the break is, we can cast it properly, and that arm will heal. We can have a gallbladder attack, we can determine that with ultrasound or other ways of anatomically knowing exactly where that blockage is, and then we can have a surgeon remove the gallbladder, and it is fine. And this is correct, this is proper, this is a good way to practice medicine. And for all of those illnesses that have one cause, this works great. The problem is in what we now see in chronic illness. We have a much, much more complicated process, and the model doesn't work. And in fact, the research understanding of the model doesn't work. So that if I were going to give an example of that, I would use chronic fatigue syndrome as an example, in which patients are not just fatigued, but they can't think clearly, they get headaches, mostly migraine headaches, they have irritable bowel, and they can't sleep, and they are not refreshed by their sleep. And medicine has wrestled with that for the last 25 years,
Yes.
as we've had literally an explosion or an almost epidemic of chronic fatigue without much of an understanding. Early on, we realized that 60 to 70% of those patients had Epstein-Barr virus. We realized that 60% had HHV6 virus. We realized that 40 to 50% had cytomegalovirus. We realized that a large percent of them had Lyme disease, or exposure to mold, or other infections, including chlamydia pneumonia, mycoplasma pneumonia that were chronic. But from a conventional medical standpoint, they were really, really adamant that we needed to have one thing explain everything.
Right.
And so that was not adequate. So since none of these 100% of the time explained it and did not provide a treatment that would apply to 100% of patients, the model just said, this does not work. We do not know the cause, we have no understanding of the cause, we do not know how to treat it, we'll have to go do more research until we figure this out.
Okay.
That's where the alternative, holistic, complementary model began to take shape, because it was obvious that the one cause, one illness, one treatment concept does not work for chronic illness. The research doesn't help us because it becomes seemingly obvious that all of the above are players. It isn't that for a given individual, we don't know which of those infections will be players. It could be all of them, it could be a few of them, it could be one of them, but the key is for that individual, which infections might be causative or contributory. And then we become more complicated, which is that in the face of this infection, we get inflammation of the brainstem and the pituitary. So we become deficient in adrenal, thyroid, female hormones, testosterone. Our GI tracts become inflamed and more prone to infection with candida and toxic bacteria. This turns into food allergies or food reactivities, methylation chemistry abnormalities, and we are off to the races.
Okay.
So what the new model consists of is attempting to understand, and we don't even think we have even all of the factors laid out yet, but to the best of our ability, understand all of the pieces of the puzzle so we can help that individual. And additionally, that will include emotional issues, spiritual issues, energetic issues, toxicities, exposures to electromagnetic radiation, heavy metal toxicity, chemical toxicities, and then really basic things like the water we drink, the food that we eat, our structure, which Jeff is an expert at, understanding how the whole structural component affects this profoundly. And you can begin to see that this is not a simple thing anymore. The whole model that we've used for 150 years no longer works. So we're dealing with complex medical problem solving. There's nothing simple about this, and we need to be more patient. We need to be more medical detectives, kind of delving into, well, for this individual, which ones are the factors that apply?
Okay, I think that's showing that our environment is beginning to overwhelm some of our bodies so that we can't handle it. So there could be a variation of different factors that essentially cause our bodies to become depleted and exhausted and ill.
Yes.
And so when Jeff and I work together, he asks me to work on the first and most basic portion, which is nutrition. And so I'd like him to talk a little bit about how he started bringing in more nutrition, which can, in essence, set up the body for more of a chance to heal with these other types of therapies that make almost a team effort in order to heal some of these chronic illnesses.
Yes, and I'll just start back a little bit, that one of the osteopathic concepts is that the body has the ability to self-heal if given the right circumstances. And when I first started practice, it looked like people were getting better. And maybe I was arrogant and thought I was just getting them better, or I actually think they were getting better faster. But as time went on, people weren't getting better faster, and I didn't understand why. Early on, at that point I started getting exposure to this idea that what we eat could affect us. And I had my own experience where what I ate affected me negatively. I was eating really good corn-fed beef from Nebraska and Colorado, and I got sick from it, and I became a vegetarian, and I got well. Looking back at it, that was in the early 90s, I probably could have gone organic and probably stayed healthy. But they were changing the foods on us, and my whole body, my being, was reacting to it. So what does that mean? How does nutrition play a part? Why does what we put into our mouth have a matter at all? And some of the courses I took early on stressed that our gut, our intestines, our digestive system has 70% of our immune tissue, our lymphatic tissue. That's the stuff that fights stuff. And if you insult that, you're going to be insulting your immune system. And if you're constantly causing problems with what we call your gastrointestinal immune system, you're not going to have anything left to fight other things that are in there. So many of my teachers said, you always start with the gut. In practice, what I found is if I can eliminate some of the war that's going on in the gut, even if people don't feel there's a problem in the gut, they get 20 to 50% improvement in their symptoms. But more importantly, they start balancing their immune system, because that's what they need to fight their illness.
Right.
Too.
Yeah, so we generally would start by introducing the concept of changing somebody's diet, which I think we have probably, as it's said, it can be more difficult to change somebody's diet than to change their religion. Okay, because we're pretty addictive.
think that was Sid Baker.
Yeah. We're-
That would fit.
It's a very difficult concept, and I'm sure you run into this, that people would prefer, they would take supplements and pills over changing their diet. And what's your experience with how you integrate the thought of improving their nutrition and adding supplementation that you feel is necessary, and perhaps even some drug therapy?
The two biggest pieces of that puzzle to me are food allergies and overgrowth of yeast and bacteria in the gut, and not having enough good bacteria in the gut. And as Jeff points out, that has a profound effect on the immune system. It also has a profound effect on how the brain works and on mood, because there are more
Absolutely.
neurotransmitters produced in the gut, neurotransmitters being things like serotonin and dopamine and epinephrine and norepinephrine. There's more made in the gut than's made in the brain. And so what we eat has a profound influence on that. We have phrases in our language like gut feeling that may be more actually correct than people realize. But
Okay.
moving back more directly to the question, I was fortunate enough early in my career to run into a physician named Bob Anderson who taught me about food allergy. And this was at a time when my understanding of allergy, particularly food allergy, was that things like shrimp or strawberries or peanuts could produce an immediate inability to breathe,
Yes.
hives, which we now realize is called an immediate sensitivity reaction. And those are relatively rare. We see them, all allergists agree that these exist, all physicians agree that we have these reactions. But what I didn't understand at that point was that we had what are called delayed reactions, which were created by IgM and IgG antibodies, and those were distinctly different. They did not involve respiratory difficulties or swelling of the tongue and the throat or hives, but they could be delayed by up to 3 days. And those involved things like joint pain, difficulties with the bladder or urinating. It did involve things like asthma, eczema, various rashes, a wide variety of illnesses. He suggested that, yes, it's very hard for people to really change their diet. And so what I wound up doing was begging and pleading.
That sounds like us, bargaining.
I have no shame.
We bargain all the time.
Begging and pleading people to,
Yeah.
for 1 week,
Yeah,
avoid the main culprits in most food allergies.
right.
And those are wheat and milk products are number 1 and 2, and then corn, sugar, citrus products, in the meat family, pork, and then for joint pain, the nightshades, which are potatoes, tomatoes, green pepper, and eggplant. And I would say, please, do this for 1 week. If nothing happens, I will get off your back and I'll leave you alone. But if you feel better,
Yeah.
anywhere from 20 to 80% better, let's explore that. Let's then add things back one at a time and see how you do with that. And I found that patients really were willing to do it. They weren't willing to commit to anything more than a week, but
Right.
if within that week they could really tell the difference, now they were interested. This went from being an oddball concept to, wow, this might affect me. And then once they began to get interested in I wonder what else I'm doing
That's right.
is making me sick. Now we have a therapeutic relationship going, and then we had more to work on.
Okay, yes, we use the comprehensive elimination and challenge diets, and he can tell you, often we start with just one thing. Phil, just do one thing, and then we'll work into it. But you can share.
Yeah, I mean, the interesting thing is, I like to be all or none, and that's why I send them to you, because you're much gentler than me. Say, look, this is what you gotta do. She says, well, let's do one thing at a time. But either way works, but
I'm going to put in a plea for the more comprehensive way. And the reason for that is that this is my big chance to hook someone and get them interested. And if they are allergic to multiple foods, if you are allergic to wheat and milk and you continue to have milk,
Right.
you may miss the biggie in your diet. And so yes, my patients will start to negotiate.
Yes.
How about I do this one at a time? And that's when I do even more begging, and I go, please, 1 week. That's all I ask.
No, I'm with you on that, and that's why I shoot for everything. And there are things that I call opportunistic allergens too, which they may have never been allergic to, but since if they maybe started with wheat or dairy as their allergy, as their gut got eroded and more sensitive and things got seen by their immune system that shouldn't have, then they're allergic to 50 things on an allergy test. And so we need to try to eliminate as many of the big things as possible to get you feeling better.
Yeah, but if I can get somebody started, and then I say, you do this, and then in a month, we're gonna do this. Sometimes that prepares, that sort of seeds the thing, and, I'd rather they did it all at once too, trust me.
There are many ways to do things right, and again, sometimes you do have to negotiate with an individual and go,
You do.
okay, try this.
Do you know how many tissues I've had to bring out because they've started weeping from missing their foods? But what else happens is that a whole array of emotional issues come up because they had to change this one thing. That's generally where it comes in.
And that's therapeutic too.
It is therapeutic. So now,
It takes a while, even when
Yes.
I personally am gluten intolerant.
right,
It takes a while for anybody to really comprehend what that means and to really take
correct.
it seriously. So, we do bargaining, we do negotiating like people do with God sometimes, which is, okay, buddy, maybe I can handle a little bit.
that's right.
And all human beings do it, even though when I finally really grasped that this was a real thing and there was no way I was going to win this argument with my body, it was still maybe I could have a teeny bit of this and get away with it. And my body let me know very, very quickly that it was not negotiating. No hostage negotiations here whatsoever. This is the way it is, Neil. You can either hurt yourself or you can pay attention.
That's right.
And eventually, like most people, my body convinced me. It wasn't, a physician convincing me. It was my body convincing me that, okay, this consistently happens. I do this, this happens. Okay, for 30 seconds of bliss and eating a slice of pizza, do you want to be going to the bathroom for the next 5 days?
Yeah.
And which is my issue there. And the answer was, not worth it. But again, it took me months to really, really, really be clear
on that.
It's not worth it.
That's right.
Because I really didn't want to be one of those people who goes into restaurants and talks to the wait person and goes, I'm allergic to this and I can't eat this, and what do you have on your menu that I can eat? And I just didn't want to be one of those
That's
people.
right.
Well, I is one of those people.
That's
and,
right.
And that's what I need to do.
Right.
So,
And we've found that too.
yeah. So it takes a while for us
It
mere
does.
humanoids to
That's right. It's
grasp it.
sometimes grasping one issue. Okay, let's just go with gluten-free, for example. That's a little bit of a learning curve for people because it's not just bread anymore, all right? So if we can get them just on that one, in the learning curve so that they're experiencing, exploring, and making it a positive thing, an empowering thing, which is what you find. You're actually empowered. It's not, you shouldn't feel bad about it, you shouldn't feel guilty, we shouldn't feel picky.
Yeah, the way I describe it to my patients is, okay, this would be very much like poison. So if you were to tell me, I just like a little bit of arsenic and strychnine in my food, you would think that would be a silly, crazy thing to say.
Right.
But that's what it is.
Yes.
Because it's poisonous to you. And a lot of my patients have liked that analogy. Because once they get it in their head that, I'll put it in personal terms, I'm not being deprived of a food that I still like.
Right.
I still dream of pizza. But I'm not being deprived of it. I can't do it. It's simply toxic to my body and detrimental, and I'm just not willing to do that. And there is life after pizza.
There's life after pizza.
Yeah.
And we live that life
Yeah.
also. I mean, Jeff and I live on the most incredible foods, and we learn to taste better. Your taste buds change. So now going kind of working past the dietary, once we kind of, so again, we're working with the patient, and in you're educating them. It takes time to do that. Now the current medical model says in 15 minutes you're supposed to be in and out and be educated and on your way to health.
7.
7 minutes? Oh, wow, that's got
15 minutes is a complete office visit
Okay.
with a physical.
Right.
7 is more typical.
So now, yeah, so he, as a specialist, Jeff can go longer than that. But he's using his hands-on, and so then he uses me to finish the education. You have a different system because you're not taking insurance.
Correct.
And it allows you to practice the way that you deem necessary for your patients.
Right, and we had talked previously about the medical model, but with the advent of managed care, physicians were being pushed very, very hard to conduct all of their business in 7 minutes. And I'm barely getting the patient's name in 7 minutes.
Right, or facing the electronic medical records.
Right, and now the electronic medical records, I'm not even looking at you anymore, I'm doing
Right.
this. So all of this distances us from a connection and the need. I mean, understandably, you can't look at all of these multiple variables in 7 minutes. My shortest office visit is now a half an hour. Even that's barely enough to scratch the surface. We have so many things that we need to go over so that the model doesn't fit what we need to be doing. And again, the model's fine for a strep throat.
Mm-hmm.
I can do a strep throat in 7 minutes, but I can't do anything more complicated in that period of time.
And for your work, you do a little bit of talking
And hands-on. And would I like to have more time? Yes, I would like to have more time, many times. In simple cases, I probably have enough time. But as we have to start looking at gut and looking at hormonal and looking at toxicities, just to even bring a patient into any understanding of what we're talking about takes a long time.
Right. These are all new concepts, and you kind of have to start planting seeds, giving patients resources, things to read about, things to study. It's a whole different model, and we are evolving that as we go. Jeff and I have been involved in this for a long time, and we're still evolving this model. But this is the model that we'll eventually need. It cannot be done in the current system.
right, the typical family practice doctor is essentially owned by the insurance company if they're taking insurance reimbursement, and have to, pump in that model of medical care, and then it's generally based on applying drugs to almost any given situation, correct? I mean, you're talking about...
That's the only answer. If I have 7
Right.
minutes and I can't do anything,
And he prescribes.
and I have someone who needs something from me at this visit, what else can I give them but a piece of paper that allows them to put something in their body that might be helpful? And I ran into this many, many years ago when I was in the Indian Health Service in Oklahoma, and needed, as part of my practice then, I was seeing 100 people a day. And what I realized was, and I had to, by the nature of my work, we had to stay until everyone that was seen that day. That was our contract, and we couldn't leave. And you can't do that. It's physically not possible. So someone would complain of something, and I knew that I had no more time to deal with it. I would give them a prescription and we'd go on. And what I realized is that I'm seeing the same 100 people next week because I haven't solved any problems. But I still can't make any headway in that because I don't have any time. And that was when I realized that I can't practice that way. And that was before managed care even hit the pavement. I realized that you need an adequate amount of time. If I could have solved those problems, there wouldn't have been 100 people a day. But I couldn't. This vicious spiral of not ever being able to get ahead. I think that's part of where we are now.
Right. And a lot of the doctors out there get frustrated, but they don't know why, because the patient keeps coming back and saying, I have this problem. And they say, oh no, you don't have that problem. Maybe you should go see this psychologist over there.
Right.
Come to us and they actually have problems.
So now, your experience as a family practice doctor, you ended up leaving being a family practice doctor, so why is that?
That's a good question. In family practice, I worked, actually I used to teach family practice when I was in the Air Force as part of my payback. I was a family practice instructor. And when I went out into real practice, I went into this practice with multiple doctors. They were going to let me do my osteopathic treatment, and they were going to, give me 4 patients an hour, which it's barely enough time, but for acute things, you might be able to sneak it by. But what happened in my practice is I would be scheduled for 4 people an hour, but they'd sneak 3 more in an hour. And I have no idea how my colleagues could see 7 people an hour. And I would, by the middle of the morning, be apologizing to my patients who've been waiting for 50 minutes to see me, and they're angry. And so I was off on the wrong foot to start with, and then I was trying to catch up, which was off on the other wrong foot to start with. And then I found that what I was doing wasn't helping people. If I prescribed a drug, if it was for strep throat, it would work most of the time. But with their more complicated problems, it wasn't working. Some of my teachers say, if you don't know what to do, my osteopathic teachers, put your hands on them and treat them. And when I did that, people got better. And I got information from them, from that whole interaction as to what else might be going on. And I decided that I can't do that in that model. And so I left and did some emergency medicine part-time and established my practice as it is now, part-time until it became full-time.
It's interesting. So, family practice model, not working well. And now you have all these PCPs that have been bought by large hospitals. They've been sort of absorbed into that, I believe, these family practice. And there's even more pressure.
They've lost control. And I just wanted to back up. The whole family practice model, as a family physician is taught, it's a really good, it's a decent education. We're taught to look at everything, from emotion, all the things that you said, that's what we're taught to look at. But we don't have time to do it in that standard.
You're taught to do it, but you're not given role models
Right.
who show you how exactly do we look at emotions and spirituality and all of the components of that illness in the amount of time that's allotted. And again, in the managed care model that's being used, there's enormous pressures on physicians to keep it to 7 minutes. There are productivity measures. They're being monitored. It's all computer generated. So at the end of a month, the administrators of that clinic can go, well, you didn't see enough patients. You weren't working hard enough, and so we're paying you less this month. So your income depends on your matching that productivity. Your livelihood depends on that. And it's not hard after a while to just get sucked into that mire of, well, I guess that's what I need to figure out a way to do. And many of my colleagues are very frustrated by, they know that they're not practicing. These are still people who want to do service. There's still people who want to help people, and they know they can't in the model that they're laboring under.
Yes.
So I know you often have patients that have exhausted some of their current medical needs.
The health system we're evolving into, we don't know where that's going. Obamacare is not a defined entity. It's an idea which is going to be modified many, many, many times over before it actually becomes reality. I know that there are people who are all up in arms about it says this and it says that. The history of the way these events occur is such that it will be different by the time it actually takes effect. But it is still essentially using the HMO model, which is very flawed for much of the immediate healthcare delivery for people who have no healthcare dollars. So for the people who have chronic illness, we're going to have a two-tier system. I can't see it being anything else. Unless Obamacare embraces this model, and I do not know if that's going to happen or not, the indications currently is that it may not, then patients are going to have to be their own advocates and find their information, what works for them elsewhere. And that's the same model that exists in Canada and England, where you can get the conventional health care, but you can then choose to go outside that model to get the care that you want. I think that's what we're looking at.
Yeah, okay. And any thoughts, Jeff?
Yeah, I mean, I think our model works really good if you're having an acute heart attack, an acute stroke.
Operations.
Yeah, gallbladder that went by, but it works really poorly for how did you get to that point and how can you avoid it? And with everything being instant and our environment changing and our foods not being real foods, we're going to see a lot more sick people. And I don't think the model is going to keep up. But the good news is there are a lot of physicians and practitioners who are really looking to find out really how to get people well. And although it's harder for us to do this, people like Neil are willing to teach people like me and offer information. And as I learn, I'm willing to teach people who are willing to learn, and I think more and more people are getting interested in it because they're finding it's not working.
Right. Well,
and that's the good news.
We've learned, we have some answers, and that is what's exciting people. But I wanted to expand a little bit on what you touched on there in terms of the toxicity of the world that we live in. That there is no question that we're seeing an epidemic of chronic fatigue, fibromyalgia, autism, Lyme disease, immune deficiencies galore, and there's no evidence that that's slowing down. And I believe very strongly that it's because of these toxicities. Our chemical exposures, our electromagnetic exposures keep growing astronomically with no one really looking at that and researching that. And I personally think that that is a major contributing factor to these illnesses. And when you said we're going to be seeing more of this, we are and we will.
Yes.
So we're going to come up against a growing number of people who have these chronic difficult conditions whose needs are not being met by the medical model, and something is going to have to give.
I agree. And what I'll add to that is preventative medicine, that when you eat right, that's the first step, okay? Clean food in the body. We cannot always control the kind of chemical exposures that we're going to have, or the kind of electromagnetic exposures that we're going to have, or a nuclear disaster that we're going to have.
Or continue to have.
Or continue to have. However, we can really clean up at least as much as we can in our own personal and what we put in our mouths. And there's a lot to that. So thank you, Neil.
Thank you,
You're very
Jeff.
welcome.
No, you're
And
welcome.
it's been fabulous. Thank you so much for having us in your home.
I always welcome you.
We've had a blast out here in California, so I want to come back.
Fabulous. We kind of want you to come back.
Yeah,
I
we'll be back.
think about Germany. That's always-
Yeah.